This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now, if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to go over static manual release of the scalenes. That's the anterior, middle, and posterior scalenes. I'm going to have my friend Melissa come out. She's going to help me demonstrate. Now we're going to use the same four-step process we've used for all of our static manual release videos. In this case, I want to start with step 4 and talk about patient or client position. Notice that I had Melissa come out and lay down immediately. I have seen texts and videos that refer to scalene release in the seated position. It's hard for me to believe that it would be easy to palpate or release these muscles in a seated position where the scalenes, as well as the other lateral stabilizers of the cervical spine, are going to have to remain somewhat active to stabilize the cervical spine and head against the force of gravity. If you have somebody laid down, all of this stuff relaxes, which means now we can get our fingers in here so we can actually find the scalenes and get a good release. Now, trying to differentiate the scalenes is not easy. I see a lot of people just kind of going at the side of the neck, and I feel like they're almost just hoping that the scalenes are in there. But there's some other stuff in there too that we've already talked about in some other videos, like the levator scapulae and the splenius cervicus. So we need to figure out, how are we going to differentiate these tissues? Well, first let's start with identifying where the posterior cervical triangle is, because I know that my scalenes are in there. The posterior cervical triangle refers to a triangle that has the SCM as its anterior border. So Melissa, go ahead and you lift your head. If you guys have somebody turn their head away and then lift up towards the ceiling, their SCM pops right out. That's easy to find. All right, so I'm going to make sure I can feel that border. I have it identified. I know where it is. And then this mass right here is her upper trap. That's the posterior border. And then the bottom of this triangle is actually just kind of the top of the shoulder girdle here. So inside there is my scalenes. All right, first step, done. Next is going to take a little functional anatomy knowledge. So I know that my scalenes, anterior, middle, and posterior, come off the transverse processes of my cervical spine. The transverse processes are not something that you want to jab at, but you can palpate by gently kind of letting your fingers depress into the side of the neck and looking for what feels like bony spines almost. They're kind of spiny. Don't press real hard, but you'll notice that they definitely feel different than soft tissue. Transverse processes feel like they're not going anywhere no matter how hard you press. Soft tissue, obviously, you can kind of almost feel like you're going to push through. Once you find those transverse processes, we now have a good idea of where the origin of these muscles are. The insertion is in the first and second rib. Now, if you've never felt the first and second rib, these aren't your first and second ribs. I know that seems a little counterintuitive, but generally speaking, the first two ribs underneath the clavicle are your third and fourth rib. Your first and second rib almost exist behind the clavicle. They're much smaller, right? They almost exist in this space here, just above the lungs, really. So how do I figure out where those first and second ribs are? Well, the easiest thing to do is probably find C7 spinous process. That's the biggest spinous process at the bottom of the base of your neck, right here. All right, so if I find that on Melissa, and then I fall off laterally, now what you're probably going to have to do is flex the neck towards the side you're palpating so that the trap will calm down. Once again, you'll feel something that is definitely not soft tissue. That's definitely a bone right there. And sure enough, right there, I'm gonna go ahead and move this so they can see. Now I wouldn't have to move her strap for any therapeutic reason. I can get at her neck without moving that, but I want you guys to be able to see kind of where my hand is. If I push down right there, that's definitely bone. Well, that's my first rib. That's my first rib. And then if I know where C7 is, I could go to T1 and try to see if I can palpate the second rib. A little harder palpation there, guys. It's almost easier to just kind of step off inside the AC joint here, right? So clavicle, acromion shelf. And if I get in there, I can kind of feel the second rib. That is one of those points where it's really helpful to have some live education or a mentor kind of demonstrate those two techniques, because it's not easy to find those in the soft tissue here, guys. But with a little bit of patience and maybe a colleague who's a little patient with you, I think you guys will find them. At the very least, you know that there's this bony floor to this area right here at the top of the shoulder girdle that your scalenes attach to from the transverse processes. So hopefully you guys can kind of summarize that. I'm looking for something inside of this posterior cervical triangle that goes from the bony spikes on the side of the cervical spine to the bony floor at the top of my shoulder girdle. Now, going back to those bony spikes, if I start up closer to her head and I go anterior to posterior, kind of over but not into those bony spikes, I should start to be able to identify some very vertically aligned fascicles. Well, my scalenes are very vertical muscles based on what I just told you they attach to, being the first and second rib and the transverse processes. Something like my levator scapulae, which also attaches to the transverse processes, is going to have a little bit more of an angle going towards posterior. If you're still having a hard time identifying these fascicles, what you could do is use your two fingers, right, to palpate in this posterior cervical triangle, but then have your client like push into that same palm a little bit with some lateral flexion, right? That'll get a bunch of stuff really active, including the SCM, which you palpated earlier. But then if they go into just a little bit of flexion, which is lifting their head off the table, you definitely would inhibit the levator scapulae. So now you know that as long as you're posterior the scalenes, or posterior the sternocleidomastoid, you're in the posterior cervical triangle and you're feeling vertical bands, that's definitely your anterior and middle scalene. All right, so now that we've found the anterior and middle scalene, we do have to talk for a second, step number 2, which is what structures are around these structures that I could insult, abrade, injure with compression. We have the carotid artery. Let's stay away from the carotid artery. We don't need anybody passing out on us. I think you will find that if you gently apply pressure rather than just aggressively going in, that you would find a pulse well before you would ever occlude an artery. And there's nothing wrong with feeling a pulse, but it is a good sign that you should probably press somewhere else. Remember that a carotid artery isn't very thick. All you have to do is move a few millimeters in any direction, and I think you'll be able to change your finger angle to still get at the same fascicles without occluding that artery. The other thing you might want to stay away from is there are little beads in here which are lymph nodes. You don't want to like take one of those beads thinking it's a trigger point and press it up against the transverse process. That's a very bad idea. We don't want to try to crush lymph nodes. It's going to cause inflammation. It could cause some symptoms that we don't want to deal with. Last, your brachial plexus actually pierces between your anterior and middle scalene. That's its normal course. It comes out those nerve roots, right? And all those various nerve roots combine to become the brachial plexus, and it comes out between the anterior middle scalene and goes underneath the clavicle and underneath the pectoralis minor and then feeds all the nerves to the arm, right? We don't want to push on the brachial plexus because A, we could cause some nerve symptoms. We don't want to cause tingling. We don't want to cause something that's going to almost look like a radiculopathy. We don't want to cause numbness or that nerve pain. We don't want to push down on the brachial plexus and create that searing, burning stretch I'm sure some of you have felt when you stretch a nerve. We want to stay away from all that. So if your client complains of any of those symptoms, once again, all you got to do is move a couple millimeters in any direction, maybe change the angle of your thumb, and you should still be able to get at those same tissues. So, I know this is a lot of information, guys, which is why I'm glad this is on video. You can put it on repeat a couple times, but let's review. You have posterior cervical triangle. We know it's in there. If I want to differentiate my anterior and middle scalenes from my levator scapulae, which is probably the only other issue we have, or maybe the splenius cervicis, I can use a little bit of lateral flexion and then flexion off the table to make sure I start there. Once I've found those vertical fibers, to find the densest fascicles and to find these trigger points, tender points, points of acute hyperactivity, I'm going to do my anterior to posterior strumming, since these are vertical fibers, as I move from inferior or superior to inferior. And our common trigger points are actually much closer to the ribs. So I think what you guys will find is 9 times out of 10, rather than there being trigger points up in the middle of the neck, they're much closer to the base of the neck. All right, so I can actually feel here in Melissa that the tightest fascicles are right about there. I don't feel a pulse. Any nerviness? No nerviness, no little lymph node type feeling beads. All right, and then I can feel that it's a little denser there. It gives me a little nodule. All right, so I can hold that for my 30 seconds to 2 minutes until I get a nice release. Guys, an important thing to keep in mind here is I'm not pressing lateral to medial. I'm actually pressing, I have a little lateral to medial angle, but I'm mostly pressing superior to inferior. Right, so I'm pressing towards the rib. The reason why that's important is pressing into the transverse processes is going to be painful. And I think as soon as we stimulate pain, once again, it becomes very hard to get a release. I know that this is not comfortable for Melissa, but there's a difference between this and pinchy pain, which just does not feel good. Now, to find the posterior scalenes, all you have to do is keep all that anterior to posterior strumming in mind, but then think, okay, my posterior scalene goes from C6, C7, transverse processes down to my second rib. So it's almost like that splenius cervicis pocket that we talked about in the splenius cervicis release video. But rather than go towards the laminar trough back this way and towards the spinous process, I'm going to go kind of out this way towards the second rib, and the fibers I'm looking for are much more vertical. This is a good technique to pick up because posterior scalenes tend to get very overactive. And I can just do the same thing. Again, if I needed to try to differentiate, for example, the posterior scalene from the anterior and middle scalene, I could go lateral flexion into my palm. So Melissa's pressing into the arm I'm using for release, and then if she extends back into the table, boom, right? All of a sudden her anterior and middle scalenes calm way down, and her posterior scalenes fire up. Just like with all your techniques, guys, take your time. This is not a race. Your patient has no idea what you're doing. Your patient has no idea how long this is supposed to take. I know you want to get a lot of work done, but I used to hate when my mother said this, but I'm going to tell it to you guys. The quickest way to get anything done is to do it the right way the first time. Man, I used to hate that, but now it makes so much sense. So take your time, use lateral flexion, use flexion and extension to help you differentiate tissues. If you have to use the SCM technique of contralateral rotation and flexion to find the SCM, great, that's fine. If you have to sit there and find C7 to find the first rib because you've never felt that before, fine. If somebody has anatomy that's a little different than you're used to, somebody's a little, maybe a bigger person or a more muscular person or much more slight than you're used to dealing with, all these little cues, knowing your functional anatomy and taking your time with your palpation will be your savior. You can still get to all of these tissues in just about anybody, and you should be able to get to them comfortably without causing discomfort from impinging a nerve or whatever, just simply by keeping your functional anatomy in mind. Stay tuned for the close-up recap. In this close-up recap of our Scalene static manual release, we're going to start by outlining that posterior cervical triangle. Melissa, if you would lift your head real quick, you guys can see there's SCM. Okay, so this mass right here is the upper trap, so we know we're going right in between the two in here, this being the floor of that triangle. Now, the first thing I'm going to look for is those transverse processes, because what I don't want to end up on is end up back here, where it's more likely that I'm going to release my levator scapulae and spleniae. I want to find the origin of these muscles so that I can start doing my anterior to posterior strokes towards their insertion down on the first and second rib. Now, if I'm having problems finding those muscles, like they're not popping into my fingers, I'm not feeling the strands, or I think by chance I'm on either the levator scapulae or spleniae, I could have Melissa go ahead and kind of push into my hand here a little bit with lateral flexion, and although the SCM puffs up pretty quick, I know that's my SCM. If I have her then go into a little bit of flexion, I know that the muscles behind my SCM that are puffed up from lateral flexion and flexion are my anterior and middle scalenes. This flexion inhibits my levator scapulae and spleniae muscles. So right there, go ahead and relax, Melissa. Right there, I know I'm on nothing but scalene. Now, of course, I can do my anterior to posterior strokes here, looking for the densest fascicles. Once I find them, I'm going to go ahead and apply pressure. Now, of course, since I'm in the area of the neck, I am keeping in mind, do I feel a pulse? Am I getting any nerve symptoms? Does Melissa have any tingling or numbness? Does she have that searing, stretchy pain of stretching a nerve? Am I on a lymph node? Does it feel like I have a little lima bean underneath my finger? Remember, these densities inside muscle just feel like an increase in tissue density. It might feel a little ball-like, but it's more just denser parts of the same structure that you're feeling. Now, to find the posterior scalene is a little tricky. I suggest going anterior and middle scalene first, and then what you can do is ensure that you're down low enough that you're lateral to C6 and C7, right? Because that's where your posterior and scalene originates. And then you can have your patient do lateral flexion into your hand again and extend back into the table, and you'll feel those fibers pop out, right? So if you know you're pretty close to anterior middle scalene, come back onto where you think posterior scalene may be, and then you confirm by doing lateral flexion and extension, you're probably in good shape. Go ahead and relax. And man, posterior scalene definitely gets tight on a lot of people. The common trigger points for all of these muscles, guys, are very close to the first and second ribs. So right about where my thumb is at, right at the base of the neck. There is a common trigger point for anterior scalene that's up a little higher, about midway up the neck. But again, these are all far more common down here. And as I suggested in our further away shot, supine is probably the best way to get this technique done. This isn't uncomfortable for me. I can get my arm behind my direction of pressure, which is going to be down towards the rib, right? Not into the transverse process, but down towards the rib. And of course, my patient here is very comfortable as she's just lying with her head supported. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, One-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.